So I have no financial disclosures to make. And my objective in this brief presentation is to provide you a background for understanding health policy and health economics, to really give you some of the vocabulary that you would need. A lot of what we're going to talk about does have its own language, and for those of us who are involved in this, we're used to this vocabulary, but this is a vocabulary that all of you need to acquire to be able to talk to your hospital administrators, to be able to talk to your legislators. And I'm going to review also the process for determining CPT codes, how they're valued, their coverage and payment. And I'm going to try and do this in 10 minutes or less. So you've seen this slide before. This is really what the world looks like, but this isn't something you can cover in 10 minutes. So I have to simplify this. This is a little more simpler, but I don't think I can cover this one in 10 minutes either. So I'm going to use one that's from FACR, and what this does essentially is shows you how we have a patient or an employee and an employer, because we are in a predominantly employer-based insurance system. The patient and the employer both pay premiums through a health insurance company that actually often goes through a radiology benefits management company and ultimately issues payments. On the top half of this, what you see are the taxes paid by the patient and the employer going through the federal and state programs and covering Medicare and Medicaid and issuing payments. This is probably the simplest model that you could diagram out for our healthcare system. And the problem with it is an oversimplification. So you have to think about what's missing. As much as there's a lot of material on that slide, what's missing? What's missing is there's 47 million people who are uninsured who aren't in that system. The VA, our Veterans Administration, TRICARE, the military medicine, that's not actually in that diagram. What else is missing is pharma and the device and equipment manufacturers. And all of this system was actually independent of clinical outcomes. It's traditional fee-for-service. And of course, we left Congress out, which, as you've heard from Bib's earlier presentation, plays a very big role in this. So what I'm going to try and do is take you through how do we know what we're getting paid for or what we're going to get paid. There needed to be a common vocabulary, and the common vocabulary that's used is a distinction between procedures and indications. So CPT codes are what AMA has developed and updates to use as the procedures. This describes the service that we've provided to our patients. RVUs, or relative value units, these are values assigned to the individual procedures. And just because you do a procedure and because it has value doesn't mean that you did it on the right patient or for the right reason. So the ICD-9 codes, which is an international classification, is used to describe the clinical scenario or the indication for those procedures. And even if you have the right CPT code and you did the exam on the right patient for the right reason, and there's a value assigned to that procedure, someone has to decide whether that procedure is actually covered by that insurance plan, and separate from that decision is whether it's paid. So this is a poster that we had at RSNA this past year, and it shows you 5 large gears. If you look at the blue gear with the CPT in the center, this is really the beginning of the process. You have a CPT code that is submitted to AMA. There's a process that goes through reviewing the CPT code and actually defining that scope of service. As you get into the RUC, there's assignment of value to that. And you see a small purple gear that says ICD-9 code. As the CPT code and the ICD-9 code get married together, that's where coverage decisions are made. And in the orange gear, Medicare has one process for deciding how they're going to how they're going to agree on coverage and which procedures would be covered. And the bottom half of that circle, the private carriers have a completely different process. So you can end up where a procedure is well defined, has value, has clinical indications, but nobody pays for it. Or Medicare may pay for it under one set of indications, and Blue Cross Blue Shield may pay for it under a different set of indications. Just because they've agreed to pay for it, it's actually a different process to decide what you get paid. And that's that red circle, and that's where we see the other small gear, which is MedPAC, which weighs in on decisions both on what should be covered and how it should be paid for. In Medicare, the physicians have a physician fee schedule. The hospitals have HOPS, the outpatient prospective payment system. The private carriers have different but parallel processes for this. And ultimately, in the green circle, you may get paid through a payment delivery system that is independent of your hospital because you're billing just your professional fee, or you may be billing globally, or you may be in some type of a bundled or ACO model where dollars come into the organization and then have to be distributed. So this is an interactive question. So if we can begin the clock. Which of the following are critical steps in the process from defining a CPT code to payment to the radiologists and hospitals? A, to define the CPT code. B, to assign value to the code. C, to have coverage policy approved. D, to have payment policy, or E, all of the above. And the correct answer is all of the above. Good job. So what resources is the college making available for you? The poster that you saw that has all the gears with multiple different steps, that along with a glossary of terms will actually be on the website for the meeting under member services. It's important to be familiar with the terms that you're going to hear today, and it's important to be able to discuss and speak that language. You don't ever want to be in a discussion with someone and say, what's an ICD-9 or ICD-10? Is that good, or what is that again? You need to be the expert, and you need to have that vocabulary. I just want to thank my co-presenters on the poster, Dr. Abrams, Dr. Dusek, Dr. Thompson, and all of the ACR economic staff, the HOPS committee, and my team back in Georgia. And I especially want to thank the CMS staff that I get to work with. It's a good group of people. As I've said before, CMS staff has a really interesting perspective. They're more worried about making sure the patient is taken care of, and that's a good perspective for them to have. My mom's on Medicare. I like knowing all the staff at CMS is much more worried about her getting good care than my getting paid $1 more or $1 less. Thank you.